So we keep on with our program, and I am very, very proud to show to you one of our dear CoMeT members 2020 is Professor Dr. Filipa Lã. She's original for Covilhã, Portugal. She's a researcher in the departments of didactics, school organization and special didactics, Faculty of Education, in the National Distance Learning University at Madrid, Spain. She has been working a lot in effects of the menstrual cycle and the oral contraception, singing voice, also in menopause, and she has published a lot of very interesting research about this. And she was a postdoctoral research fellow at the University of Coimbra in Portugal. She also was assistant research at the medical faculty at the Division of Phoniatrics and Audiology in the Department of Otorhinolaryngology at the Technische Universität Dresden in Dresden, Germany. And she also made a postdoctoral research at the Foundation for Science and Technology in the Ministry for Science and Technology in Portugal. She has a PhD at the Music Department, the University of Sheffield in the United Kingdom. And she has a Master of Music in this same university. She also has a degree in biology at the Faculty of Science and Technology in the University of Coimbra in Portugal. She owns a diploma in Master Music at the Conservatory of Coimbra in Portugal also. And well, she's going to present herself. Please enjoy.
Dear colleagues, it is an honor to be part of this family of knowledgeable experts committed to the care of the artistic voice. And as a new member of this great family, please allow me to introduce myself. I am Filipa Lã, a senior researcher at the Faculty of Education of the National University of Distance Learning, UNED, in Madrid, Spain. There I am currently the PI of a research project on the menopausal female voice funded by the Community of Madrid under the program Atracción de Talento Investigador. Within this project, I have been able to set up a research lab in voice, music and language. I invite you to visit the lab's website, unedvoicelab.com, in case you are interested in finding more about this project. I had also the possibility of developing, together with my colleague and friend Núria Polo, Associate Professor at UNED's Faculty of Philology, an online specialization course in pedagogy and technology, voice and singing, aiming at continuing education of singers, teachers of singing, speech and language pathologists, and other voice health specialists on voice analysis, evaluation, and habilitation. This course counts with the invaluable expertise of teachers who happen to be also my collaborators and dear friends, Johan Sandberg, Sten Ternström, Svante Granqvist, and Brian Gill. But this passion I have about the singing and about the voice in general started quite early. At the age of 5, I became a soloist singer in the church I used to go in Covilhã, in Portugal, where I was born. Since then, I never stopped singing. At the same time, I have completed my degree in biology in the beautiful University of Coimbra, with more than 730 years of existence and nominated by UNESCO as World Cultural Heritage. I also completed my conservatoire degree in singing. Then I moved to Sheffield in the UK, where I have done my master's degree in performance and immediately after a PhD in music, with a scholarship offered by the Portuguese Minister of Science and Education. Since then, I have participated in several recitals in Portugal, England, Ireland, Spain, Brazil, Croatia, Czech Republic, and Australia, interpreting repertoire from early music to contemporary classical music. After my PhD, during which I have investigated the effects of the menstrual cycle and use of an oral contraceptive pill on vocal function of classically trained singers, being mentored by Jane Davidson, William Ledger, and David Howard, I have been developing research in vocal health education, being specially concerned with the artistic voice from a gender perspective, namely studying the effects of sex steroid hormones on the female voice at several reproductive stages across life, from having menstrual cycles to being pregnant and being at the menopause. During my postdoctoral years, I had the opportunity to work with a unique mentor and my dear friend, Professor Johan Sandberg, who taught me, amongst many things, how to carry out acoustical, but also physiological and aerodynamic analysis of the singing voice. He also broadened up my interests towards the singing voice in other genres like music theater and traditional styles. I hope later on I could be able to talk more about that in one of the CoMeT sessions to come. With the results of my research, I hope to improve the quality of my teaching, being able to contribute to the improvement of voice education, developing tools towards evidence-based practices in the voice studio, and contributing to the continuing education of teachers of singing. I know that as a new CoMeT member, I will immensely benefit from all the knowledge you have and you will share with me, so that I, as you do, can also contribute to the nurturing of the professional singer. Thank you for having me on board.
So this is great, Filipa. Thank you very much for your wonderful video and to share with us something of your professional and personal life, and many dear greetings to your son Taigo. And I would like very much to read a little bit about also our dear friend and CoMeT member 2020. This is Professor Dr. Sten Ternström. He is Professor of Music Acoustics and Voice Acoustics. He has a Master in Science Engineering in Electrotechnique. He heads the voice research team at the Department of Speech, Music and Hearing at KTH, Royal Institute of Technology in Stockholm, Sweden. He has the main research interests are the human voice, singing, audio technology, and music acoustics. And he is an international authority on voice analysis and on the acoustics of choir singing. He has been teaching since many years in undergraduate courses, doctoral courses. This year has 5 to 10 basic science degree projects, and also master science degrees projects 4 to 6. He has been awarded by fellow of the Acoustical Society of America, and he received an award from G. Moore Lecturer 2017 from the Voice Foundation in Philadelphia, USA. He's a peer reviewer from different scientific journals, and we welcome his video.
It's not fine to dance and sing.
The engineer in me woke up when I was 7 with my first Meccano kit. Then electronics, and in my low teens, hi-fi kits of all kinds were following me home and put sound into my life. At KTH, I learned about computers, eventually got my first own computer, and now I have access to really big toys like this one. But I'm just as happy in my little home studio. So, at the ripe old age of 19, little did I know what was in store for me. The best thing I did as a student was to join the choir. It was an amazing period. We had such fun, we learned so much, and the people I got to know there are still the core of my circle of friends. I'm not quite sure how I found the time to study, but I did see Johan Sundberg's article in Scientific American and sought him out. He suggested that I do for my master's project a church bell synthesizer for the Royal Opera, so I did, although it took me 12 months rather than the stipulated 3. And here we see Johan with this original analog synthesizer, Musse, later to be reborn in many generations during my years with the group.
So this is the iconic KTH Central Courtyard. And in these rooms, I took my first lectures in electromagnetic theory and applied electronics and whatnot. And then in 1980, I joined the music acoustics group, which was housed down here in a tiny corridor where Johan Sundberg had all of 10 square feet for his office.
Johan noticed my choral inclinations. He hired me as a research engineer. He got grants to investigate the acoustics of choir singing and taught me to do research. Only after several years was I actually enrolled as a PhD student. Things were more easygoing then. Computing and music acoustics were the only top grades I got at KTH. I never did a postdoc, but I did several pre-docs in San Francisco and in Sydney. When Windows was launched, I wrote the first sound editor for it. Jointly with Lennart Neovius and Svante Granqvist, I developed it into a software ecosystem that is still used at voice clinics around Sweden.
Of course, the classrooms are empty at the moment, but I do teaching. I have a course in sound as an information carrier for the second year media program. And I also have a course in audio technology for the fourth years of all programs. So they're not really related to voice, but it kind of reflects my interests in audio and acoustics.
So what are we trying to do now that might interest you, members of CoMeT? Well, I firmly believe that we need a new way of measuring voice, that it focuses on vocal function and not on numbers and static parameters. And I will return to this time and again. I would love to develop the successor to the old systems that we did in the 90s, clinical ecosystem, browser-based, big data enabled, and with quality control. And I would love to support the performers on stage with the science. And part of that is being able to identify the small differences that make all the difference.
So this is what I've been pretty much doing the past few years, looking at electroglottography of normal voices. And the next step will be to start applying voice mapping and EGG analysis to pathological voices. And you'll be hearing more from me about that in the upcoming CoMeT presentations, I hope.
Thank you very much, dear Sten. So as you see in CoMeT, we are a Collegium Medicorum Theatri with a lot of expertise, scientists from all over the world, medical doctors, pediatricians, laryngologists, and everybody is sharing in a very colloquial way the different ways of the science and the art. So as closing remarks, first of all, I thank you very much for staying with us a little bit more time as scheduled. And I would like to tell you that our next celebration will be in commemoration of the World Voice Day, also with CoMeT together. And we have already the program. And this is the 7th session, as you know, with the celebration and commemoration of the World Voice Day 2021 and the Voice Foundation. And our dear Robert Fatalov is going to present a very interesting, also surgical theme. And we are having the videos of our members, Giovanna Cantarella from Ireland and Adam Rubin from the States. And also, I would like to share with you that on 2nd June, we are having a CoMeT session in the Voice Foundation Symposium. Voice Foundation Symposium is celebrating 50 years anniversary. So we are going to be there with a very nice program with our CoMeT expertise members. And also a big congress is cooking with John Ruby and Ruth Epstein as co-chairs from this congress. It's going to be 3rd, 4th, and 5th of September. We are having a summer pause, I hope summer holidays on July and August, but on September we are having this 3 days CoMeT Congress with General Assembly. I also want to say hello to Alfonso Borragan from Santo Domingo, Spain, to Daniela Santado, to our dear Gwen Corby. I'm very glad she could join us from New York, and Isabel Garcia Lopez from Madrid, Joao Silva, Marco Fantini from Italy, Philip Madman from Münster, Sarah Harris from London, and Soledad from Buenos Aires, Ismail from Turkey, and also our dear friend Susan Fischer from Hamburg, and Wolfram, Professor Wolfram Seiner from Berlin. So I thank you very, very much, and I hope you are enjoying our CoMeT sessions online. And I'm sorry I am a little late, but we have now discussion for the persons who kindly stay with us. And I thank you very much, and it was wonderful to see all our dear friends all over the world and enjoy this presentation from Stephen Seitels, from Filipa Lã, and from Sten Ternström. And I think Professor Johansson was also there. I send many kisses. And I would leave the first question to Ahmed Genet from Helsinki, Finland. Where are you, Ahmed, please?
Here, and I hope that you are able to hear my voice. Actually,
Yes.
I would like to also extend my greetings to the new 2 members, Filipa Lã and Sten, and they made really wonderful introduction videos. I have this feeling that the introduction that I made when I joined CoMeT was quite boring. I'm right now thinking about leaving CoMeT and rejoining again and make a nice video like that. But I'm also thankful for Steven for the wonderful presentation. And actually, I have 2 comments, because sometimes when you have the videos, I was not able to hear your voice. And that's why I missed a little bit part of what you said. And the first thing is about the KTB laser. I guess this is the same one that I have been using here for years, and it's the Aura, and then we shifted about 3 years ago to the blue laser. It's 445, and it sounds to me, or it looks to me, that it's actually even a little bit much better, because for the Aura they are not able to fix it right now. And then when I saw the video of the operation with Tyler, there was a scar, and what I noticed is that you injected, you left in the same way the epithelium, and then you started to deal with the vessels in the back mainly. But did you do anything in the scar as well that you would have mentioned, but I didn't hear it?
No, you didn't mention it. You didn't miss anything. I don't think that's a fixable problem. I think what we have today is a scenario where you have to make an assessment, which is you do this varying pitch, how much viable superficial lamina propria is underneath it. I mean, this is a voice that's made quite a bit of money over the years. I was treating his problem. He wasn't complaining about voice issues. He has managed his voice individually for decades. The bleeding is a disaster because of the cost tour. And he doesn't have a lot of pliable tissue left. So I would never chase that kind of scar. Julie was a little different because it was induced by a surgeon and I knew exactly where it was. If I was to create that perturbated sound with Stephen, it would be the entire center part of his vocal cord. So I don't see a pathway forward in that, given what he had done to himself. And again, that's his signature at this point. And all I did do an infusion. So getting back to this, I think we can look philosophically at it and say, surgery for the most part either treats bleeding or resects lesions, lumps and bumps. The future, and I think people know this, we started writing about this 25 years ago. In the future, it'll be just as important as what you infuse in, not the saline, as what you take out. And you have to alter the pliability by adding something, and that simply just doesn't exist yet. So I think that any number of groups have, basically picked up on this through the last 20 years. Ourselves, we've been working on it. And there's a fundamental problem with trying to make this happen. And we're still at it. We just embarked on a project with the largest biomaterials company in the United States, who are generally making things for orthopedics. The dilemma is the regulatory system is designed to slow things down. That's what it's supposed to do. It's supposed to make sure the research is done accurately and appropriate. All you need to do is look at what's going on with the COVID vaccine to understand that. And then on top of it, there's such an explosion in chemical engineering that, like, a material that we were using 10 years ago was in vogue. So it was doing it, but by the time they move so fast that it's very hard to bluntly design a business plan, because it's outmoded by something else, and then you've got to start from scratch again. We have the modeling to demonstrate stuff, and it needs a tremendous amount of money to actually set a business plan in motion. But I think it's unequivocal within, I hope before I retire, I'm trying to get another 10 or 12 years out of this. I've been at it for a long time, that these materials will be routine. You'll put them in the office. They'll be tailorable. They will have a residence time of anything from 24, 48 hours to 6 months based upon what you need. And that tailorable biomaterial with variable residence time is going to completely transform voice health, voice surgery, if it can be done, have the appropriate viscoelasticity. And the fundamental problem is that things that tend to have a longer residence time are more cross-linked, and therefore they're not as pliable. So you have a push-pull in the chemical engineering. I just suspect it's going to happen, and then our entire field gets transformed when it's not going to be vitamin shots in the butt and necessarily some like massive doses of steroids. Will actually be able to enhance the biomechanical viability.
Thank you for the answer.
Thank you very much, Stephen and Ahmed. And Filipa wanted to ask something. Filipa Lã, please.
Yes, Dr. Zeitels, thank you so much for your wonderful presentation. It is an honor to see you talking about the wonders you do. I was, as you may know, I'm very interested on the effects of sex hormones on the voice, and I was wondering, in your vast experience on your practice, if you come across with this evidence that perhaps hemorrhages that athletes suffer in the case of a female may be related to specific phases of the menstrual cycle. Did you come across with that? Because I wonder, they put their voices into a lot of stress. Why suddenly one day that stress happens? Could that be a trigger point, the specific phases of the menstrual cycle, for example?
What I know about this, and it's, as you know, it's very hard to study this, because how do you separate cofactors out? The majority of hemorrhaging, I would say, where I could even get a reasonable enough history, occur in musical theater performers, less so in somebody who's touring individually, because you get to see often when there are hemorrhages, there's more than one in a play. They're facing the same other challenges. It might be a respiratory infection in the winter. It's so hard to separate the trauma from that, but this may or may not be helpful. I've had some very interesting discussions with women who were perimenopausal, great singers, and what they described. And one of the more interesting descriptions was actually, and I think she'd be fine with this, was from Federica von Stade. And she said she was simply unstable for about 3 or 4 years. And she knew what she had before, she knew what she had after, but in that perimenopausal period where I suspect there was lesser and greater amounts of edema that was happening that she had no control over, it made her very, very unstable. And there's some other great singers. So most of what I know is just clinical, observation and listening to them. But it's very hard to know that that's what happened. When did they have a tough night? Were they talking too much? Did they have a cold? So it's very hard to segregate it. But I suspect it's quite possible. I just don't know how to prove it.
Thank you.
Yep.
Thank you very much, Filipa. Thank you, Stephen. I would like to ask you, Stephen, which is your experience, for example, comparing the surgery in female during the menses and in females when they are not under menses? I don't know if you have, I mean, I don't expect any statistic, but
so anecdotally, I'm sorry.
Yeah,
so,
okay.
So anecdotally, what I would say, Eugenia, is I don't like to do it, but there could be other reasons too. Sometimes women, are just not in the best mood. I mean, they just don't want to be bothered then. So I just think in general, it's not a wise thing to do. And then probably the bigger problem is if they're taking meds at the time that might have some blood thinning effects. So I just try to stay away from that, but I won't not do it if they have a scheduling issue. So what drives me most of the time is knowing that they have not significantly used their vocal folds in the perimeter of when the surgery is. And I give them explicit instructions. They're not to do big shows and do anything quite important. They're not to be on voice rest for like 10 days before, because I don't want to be looking at a post-relative trauma scenario. So generally I want people just settled down. And I wouldn't choose to, but if someone also said to me, we got to get back into this tour in, X number of weeks, I wouldn't not do it for that reason. And I've never noticed that something has gone wrong because of that. And to me, one of the things that has happened through my career is I've gone longer and longer on the voice rest. And I believe patients who sing for a living, you tell them don't use your voice, they won't use their voice. In contrast with people, they'll never do it. They do it. If they're going to earn a living that way, they do it. In addition, just from a common sense standpoint, if I'm doing that delicate microsurgery, and it is delicate, I turn that microscope on to the highest magnification, and they're not healed. I mean, there's not a chance they're healed within, days. And then even, a woman's normal conversational voice somewhere between 280 and 240, why would you want them oscillating, colliding that many times a second in a fresh post-operative delicate procedure? It just is antithetical to me. So as I got older and saw the effects of people, let me sort of back up and say, does anyone really believe a singer who is breathing and do everything else, who is young, is going to have some type of problem forgetting how to use their vocal cords? Or they're going to just, some kind of horrible thing's going to happen in their brain because they kept quiet for a little bit? I think the stuff is bluntly a little bit silly. What I worry about is mechanical trauma to the area that I've operated on. I wouldn't do an operation anywhere and then pound it, continuously after the operation. What we learned with using the angiolytic lasers is it looks wonderful at the time, but they're gonna ooze into that afterwards. That's what they learned in the baby's port wine stains. So they're gonna get ecchymosis. If I do just a subepithelial resection, cold instruments, by 2 weeks, they're almost, if not completely, near completely healed. I won't let them get on a treadmill. I won't let them talk. I won't let them sing. And typically, if it's just cold instruments, they're totally healed at 2 weeks. They start speaking again for a week, singing, and if they've had long-term lesion, I want them to work with a therapist who is a singer. If I use the laser and I don't look at people, and I don't want to look at them 2 days after an operation. It's all blood. It just leaches into it. And it takes a full 3 weeks for the hemosiderin to break down. And since the overwhelming majority of patients that I have, either for cancer or any of this, 80% of them are coming from a distance, I can't afford to say, come back in a week, do this. So when they come back in 3 weeks, The blood is gone in almost all cases. They're going straight to do what they have to do, and I don't see them again for months on end. You'd learn to be very efficient when none of the people live near you. So 2 weeks for cold instruments, 3 weeks, if I've used a laser, so I can look at them and say, you're healed, go whatever, do what you ever want, you need to do, and just start rehearsing.
Thank you, Stephen. I'm sorry, Marcus, you wanted to ask and I didn't notice. Please, Marcus. Marcus?
Yeah.
Okay.
Steve, I think this was
sorry, Marcus, please go on.
Okay, that's fine. If somebody else is in the role.
Your micro, you put your micro in silent. Okay, now.
Okay, Steve, thanks. And I visited you some 15 years ago, and I really was a
You didn't just visit, you were here with us for a while.
Yes, right. And it was really a game changer for me to see what you're doing. And I think a lot of people now learn from you, and also your analyst article that came out 2 years ago, that was really also great and summarizes most of what you showed us. And I think that you're also doing a lot of office-based surgery, and I missed this in your talk, but yeah, you can't talk about everything that you're doing. But do you think that office-based surgery like injections and excisions is also something that you would recommend? And also the laser using through the flexible endoscope, because I saw you used your laser glass fiber transoral, is that right? So would you recommend something like that?
No, we do it flexible. So like I said, the background of the office-based was when I got the yellow light, all they had it down to was a 1 millimeter glass fiber, which doesn't bend to the contours of the nasopharynx. So as far as I know, that first procedure in November of 2001 was the first procedure. And we were using on diseases. I have, as you probably could tell, a bias to not treat anything unless it's absolutely no other choice. I don't like to treat subepithelial pathology with a laser for those reasons I indicated in the office. In the OR, of course, it's obvious because it's a two-dimensional screen, a moving target, and you can't retract tissues, so I can't use it with any level of precision. So I personally would not treat a polyp that way. Now, I have done it. One woman had a giant polyp from radiation-induced vascular lesions 20 years later, and her mandible was radiated, and no oral surgeon was going to pull those rotten teeth. So if I put a scope in her, I was going to crack her mandible, and she was going to have osteoradionecrosis. She also has a very bad voice because it was radiated 20 years ago, and I had no trouble taking care of the polyp on her vocal cord. But if I'm working on an artist, I want that membrane to be there at the end of the operation because I know from doing this for years, that's the best way. It doesn't mean you can't get it out, but in more often than not, if you do that, you either are good, you can't control the scar. That was why I showed that that pathology from Minoru. How on earth do you control where that laser is going? You don't even know because you can't even see the distance. And people should understand when you're using that style of laser, whether it's yellow, green, or blue, fiber to tissue distance is critical, how much energy goes and how much blood is there. And remember, lesions are three-dimensional. They're not sitting there. So you could be getting a small amount of energy into one area and another area gets a lot more simply because there's more blood. So it's a thing that I want to watch under magnification. That's, there's no doubt I could do it, but I don't feel comfortable that, let's put it this way. After a while of doing this, if I get a bad result, it can be really problematic. So I am so cautious about that, but it's not because I can't technically do it. I'm taking massive papilloma lesions out that are 10 times the size of whatever a polyp would be and having, you just do it, but they're not expecting to get on stage and sing. I don't know if that answers your question, but yeah, we've done 2,000 office-based procedures.
Thank you very much, Marcus. Thank you very much, Stephen. Now, Andrea Ricci Maccarini from Cesena, Italy, he wants to ask something, Stephen.
Sure.
Okay, can you hear me?
Yes.
Yeah, a little bit louder.
Thank you, Stephen. Thank you for all I learned from you. We use the KTP laser since many years, following your recommendation, and also the technique with the thyroplastic with Gore-Tex. Do you still use Gore-Tex for thyroplasty? Or
Sure
maybe
do. Sure do. You know, but I never bought the vocal cord product because when I started doing that, I had cardiac patch, which is very thin. So we just were doing that from the beginning. All it is a different, you know, it's a little thinner and so forth. But yes, I'm doing nothing different. The background on that was I went to teach the arytnopexy procedure in like 1998 or 9 at University of Cincinnati. And they had just come back from Harry Hoffman and Tim McCullough, and the head and neck surgeon there. And when we did a lab, he said, what do you think of this? I was still cutting out the silastic. And I instantaneously said, boy, this makes a lot more sense because you're doing your changes within the paraglottic space and tuning it real time. You're not out, in, out, in. So that's when I switched over, just watching what he did, that one operation, and I never put a silastic implant again practically. And I still do it the same way. Yep.
Okay. Thank you. Thank you very much.
Thank you.
Thank you, Andrea. Thank you, Stephen. I don't know if somebody from the audience want to ask some question before I miss that. Okay, I would like to ask you also about the development of the biomaterials that we were talking about, which is, of course, it sounds great to have biomaterials and to feel everything that we have to deal with pathology or with surgery. But how is the development now, Stephen? Can you please tell us about
Frustrating.
that?
Very frustrating, as it's been for 25 years. I never imagined when I went on that journey, I thought this was going to be, I don't know, 2 to 5 years, a few $1,000,000. I don't even know how many millions of dollars we've spent already. We've worked out the modeling, but it's so complicated, both for a business roadmap. That's kind of what I've learned a little bit more about in the last 15 years. There was no way in the world, which we came to the conclusion about 7 years ago, we were going to do this out of a laboratory. You need a company that does biomaterials for a living, and they have to decide that voice patients are worth it. We think we have such a company. We have the funding to drive it. They're not going to have to raise funding. But I have never been so humbled about anything in my life, because to me, this is the holy grail, controlling pliability for a tailored amount of time for whatever scenario you face. And I would say, you know, I've been so fortunate to be a voice surgeon. I think that it's been one of the greatest things that I could have achieved and done. And it's just been a great life. And my major failure in my life has not been, I have not been able to allow Julie Andrews to sing. I never thought, as she said in 1999, I could get her voice better. She could act from just routine surgery, but I never thought I would fail her. And we had many hours of conversations about this. And I realize now, you know, thankfully she's healthy and alive, but that kind of prospect isn't looking great, because I think what you need to succeed at this is so complicated, both from a biologic standpoint. We've gone down pathways, but we realized it just wasn't going to be good enough, or we couldn't put together a business roadmap. And I remain extremely cautiously optimistic, because it transforms every person on this call. Their life is transformed if somebody, be it us or somebody else, can come up with a material that achieves what I just said. The only thing I can report to you now, I've got plenty of funding, and we are working with a terrific company that's just beginning, because they do it in orthopedics, they do it in ophthalmology, and they've been convinced by us that this is a worthy use of their resources. I mean, not even the money side of it, the engineers and things that they have. So I remain hopeful, but I wouldn't say it's a sure thing.
Thank you. We all remain well, with a lot of hope. And I would say hi to Jan Beck from Prague, Czechoslovakia. and also my dear mentor, Dr. Fernando Romero from Mexico. Welcome. And I don't know if Orieta wants to ask something about the phonosurgery. Not at the moment. Well, I wanted to ask you, I'm sorry, but I have some questions, but from the audience, somebody wants to ask something? Yes, Ron. Yes, Ron.
Hey, thanks so much for a brilliant discussion and talk. When you had Joe Buck on, my computer went down, then came back up, so I missed everything about that area. Would you briefly talk about paresis, paralysis, your approaches?
Sure. A couple of things. So Joe went down. He's been very public about this. He actually, it was tough at the time. What happened was, it was like 3 days before opening season with the Yanks and the Red Sox, and he had a cosmetic hair transplant procedure. He didn't say this originally. He didn't want people to even know. He then told that story later in his autobiography a few years ago. And he was intubated for 7 hours or 6 hours. And what happened, and this is not a common reason to get denervation, it happens, but most of the time when someone's tubed, the anesthesiologist gets blamed. But of course, if they had a spine procedure, I had one, a fusion, head and neck surgeons have terrible spines. They're right on the RLN, okay? And they nail it. I can't even believe some of the things that come in and they're told the anesthesiologist did it, even though there's an incision across the neck here. Thyroid, oh, it was the anesthesiologist. So more often than not, idiopathic from an intubation is pretty rare. His was it. And what we are seeing, I have to tell you, which is a bit puzzling to me, we're seeing more of them relatively now post-COVID. Some of these prolonged intubations, I thought they were, I'm seeing plenty of stenosis, because you can imagine that tube's in there, pummeling the interarytenoid region day after day, the NG tube coming up in the gastric contents. But I've seen a fair number of denervations legitimately, and one recently was a cantor in that community in Brooklyn. It just was what it was. He was just denervated on one side. Now, our approach to this, and I believe we were the first to write this up, what we believe is that you want to actually do the injection sooner as opposed to later. My goal with that group is I can't change the outcome of the reinnervation. Is it favorable, synkinetic? Is it unfavorable? I just want them to, if we can, avoid an open neck operation, which was just asked about. What we learned is that when you're getting reinnervation, it's actually tough for the muscles to pull. Let me see if I can show you this. To pull the arytenoids up the cricoid facet, that's a lot more force. What we noticed, especially if we even went into the unit to get them basically injected so they would get out of the ICU if they had a major chest or brain surgery, that if we better position the vocal cord, some of the people would not have had favorable enough synkinetic reinnervation to reposition the cord. But if they were already positioned, it could hold it, but not pull it up the facet. So we go for very early injections, and it also is a relief to the patient. Bluntly, some of them can't swallow, and you make them more aerodynamically competent to close off so they don't aspirate. We do it very, very early, and we found that it diminished our open neck laryngoplasty procedures by half. So, and what happened with Joe just got reinnervation late. He was at 8 months. It was getting pretty depressing. I was doing local injections of Restylane. And this whole subject is, as far as I'm concerned, a bit of a nightmare. The manuscript that was mentioned about the singers and the Grammy singers, these were all papers that Larry Page helped us to fund. We built with MI2 two pacemaking devices. You know, we just went into areas we never thought we would be that intensely involved. There was also a paper which was really a bit disturbing. Most people are injecting forms of the hydroxyl apatite, or I forget which company is doing what, or it's the carrier. And the background of that is really amazing. What happened was the hydroxyl, the Prolarin plus, and one is the carrier and one is the hydroxyl apatite with the carrier. The background of this is they sent it to a number of us in the 1990s. I really wanted no part of it. Jerry Burke did a study on it, and at the time, that stuff doesn't go away. And it handles horribly, because if you've ever had the opportunity to use a caulking gun that you can't control what comes out the end of the spigot, that's what it's like pumping that through a 25 gauge needle, which you don't know where that needle is actually sitting because you're doing it in the office if you do it right for the auditory feedback. And what they realized is they had produced an office-based Teflon, but that's not what people wanted. So then they went back to FDA and they said, oh, guess what we're going to use as our short term stuff, the carrier. And they said, they actually wrote, they both last the same amount of time. They pulled a fast one on the FDA. This is why FDA gets trouble with things. To this day, the material, and this is why it's worth your looking at this paper, we did the only survival study in canines in any large mammal ever. The problem with their carrier is it's water-based and it jets like a squirt gun. It doesn't aggregate. So when you want to do an injection, you're trying to reproduce the open operation with an implant in the deep paraglottic space that pushes the soft tissue over. This stuff was jetting like liquid, and we did the whole mount sections on these larynges, and we compared Restylane, which is hyaluronic acid, which we just used the plastic surgery stuff. It works perfectly fine. So the vocal cord materials that were available are horrible. And those are the ones that are FDA approved. You have so many institutions that will not allow you to use an off-label use, even though it's the best material. So that company I mentioned to you, that's the first thing out of the gate. They're going to give us fully made appropriate materials. And when those folks all signed on that they got these results, it was virtually all gone in a week. And that there was no reason to even inject it. It was just gone. And then they were injecting it again. And it was all subjective, the studies. So what sadly is the case, you want to put an injection in early that's there for a few months so you hit the moment when you synkinetically reinnervate and hope you're there at that. And I will redo it. I just want them positioned. And then if the stuff is there, it's still going to dissolve. And if they get their mobility back, and more often than not, they don't get the mobility back, but they actually don't ever need the open operation. They're well positioned. I hope that's helpful.
Yes, Rob?
But look at that paper. I think it's very valuable. You know, I guess I can try to do it. We have a bunch of, this was a supplement to the Annals in 19 with like 7 different manuscripts. If there's a way, I'll find a way to get it to people. We've got a bunch of reprints because the patients get them. So if anyone gives an address to Eugenie or somehow, we'll try to take on the thing and just mail them out to you. There's a pretty reasonable amount of information in it. It's like 100 pages.
Thank you, Stephen. You can send us also to us, and we send it to the members. Of course, it's
sure.
It's a great pleasure. Yep. And I will please have Ahmed. You are with a question.
Yes, it's actually like from a different perspective, and I'm dealing with the fact that the aging population is increasing around the world, including in Finland here. And when we started a few years ago to augmentate the patients with atrophy, and they are usually like consultants, you know, like businessmen who like to continue and was working.
Yeah, they're working later in life and they're running companies.
And exactly, and it's like part of their image that they are giving to the ones that they are dealing with. Right. And I have been doing the calcium hydroxyapatite and for selected number of patients who still have more than a thread in the muscle. I mean, like still they have a little bit of a muscle left there. I would go and have Gore-Tex specifically in the middle parts of the vocal folds. However, do you have, because you will be working in the biomaterials, do you also have another extension that is included in the study or in the project that you have in the Voice Health Institute that is dealing with the possibility to have something more dedicated to this growing patient group?
Yes. I mean, that is, so the answer to this, I have a slightly different perception of this. I think that the majority of problems in presbyophonia, it's atrophy, but it's atrophy of the superficial lamina propria. And the way you can separate that out, they all start having LCA or lateral cricoretinoid hyperfunction, because if they're stiff in the center and they can't generate a wave, they start getting hyperkinetic. That's how you separate it being muscle atrophy. most of those folks, many of them, even they scissor their arytenoids, they're doing anything to get closure. And the more they use their LCA, we know everybody has some combination of lateral cricoarytenoid, interrytenoid, and maybe lateral thyroarytenoid to get closure. These people become LCA dominant. The vocal cords are flying all over the place and they look more bowed, but the bowing, in my view, is you're not going to have bilateral thyroarytenoid atrophy while you have the arytenoids moving way abducted, adducted, and moving, you know, very vigorously. So I've been doing what you said for many years. I will either, I actually start by doing a deep paraglottic space injection. That just gives you, and what I do that for, whether it's a Parkinson's patient or one of them, there's a few things that people don't talk about what you achieve with this. What you're, I think, worried about is the fact that the vocal fold is shaped like this. So if you dump it in the paraglottic space, how do you get it to push up? And really, some of them, it doesn't actually change where they're actually contacting. One of the goals with an open laryngoplasty or in a paraglottic space expansion is to change the profile of the medial surface. In any one of these people, there's a contact zone where they've beaten up completely. I'm sure you'd see this in Bill Clinton. And they restore the SLP on the superior surface. So what you're trying to do with these paraglottic space augmentations is change the shape of the medial surface. And if you're lucky and you can use your ear, and I do this in the OR, they start engaging superficial lamina propria that didn't have a prayer of engaging. It never got contacted. So it's just as important in a laryngoplasty to medialize it is to change the coronal section of the area of contact. And that's what's done. And I spend a lot of time repositioning the Gore-Tex to try to engage in a vertical sense, more superficial lamina propria on both sides as much as closing the hole. So when you have these people who are presbyphonic, I see them just like you. I mean, listen, I'm in my 60s now and I have no intention of stopping. I'm having way too much fun. It's more fun today than it was 25 years ago with all the technology. And now it's just a matter of keeping the rest of me going and I'm healthy. So, so what you want to do is change the shape of the paraglottic space. And for anyone who, you know, likes to do the surgery, find it online, because most people know about these papers, but there's something called coronal sections of the larynx. The Armed Forces Institute of Pathology of the United States basically put these monographs out, and it has, I have never stopped using this. It's one perfectly laid out coronal section of the larynx. They're usually not even a lot of money. It's a monograph that Gabriel Tucker, his father was Jackson's partner, and Gabriel Tucker Sr., who was, you know, the firstborn, he did this when he was at Johns Hopkins, and to this day, you just find it. It will help you with larynx surgery through your whole career. And he's the one who defined the paraglottic space, things that are on it. He actually used that monograph and showed everyone where it was. So a very important feature of what you put in. I am reluctant. I've seen so many disasters with hydroxyl. I'm not seeing the ones that work. I'm seeing the ones that go south. And when they go south, these people, you know, I had a basketball coach that was injected by a very well-known person, and he lost his voice, and I had to cut open his vocal cords to get this stuff out because it doesn't go away so fast. They tell you it goes away. The companies that put that out, bluntly, they did not tell the truth from beginning to end. Different companies own it now, never told the FDA the truth. And when they say it's gone in 6 months, there is no study on that. They don't do past 6 months. So there's a lot of issues with injectables. And I think it's sad because it's a procedure that started in 1912 with Brunings putting paraffin in there. How could we be 110 years later and there has not been more significant advancement given the level of chemical engineering since World War II? I find it astonishing. We're going to try to fix it now, but I don't know. Hopefully, if we don't, somebody will.
That's wonderful. That's wonderful comment. One of the things as well is that about the about calcium-enriched hepatitis, that it is quite sticky, and if you already have the patient having a tendency to activate or engage the false vocal folds, in some patients I found that it's much safer to start with Restylane, and that's how you will be getting an idea if this is going to go in the right way. Because if you, I don't know, but I have I had about 500, 550, and we had among them about 5 cases that actually, when I injected, that was in the beginning, was calcium hydroxyapatite. When there was a little bit of activation of the false vocal folds, it even got worse in terms of the result.
You know something, I have a general philosophy that I really don't want to change the constituent nature of the tissues that are there. And that's just, and it's reasonable when you're doing a laryngoplasty, because you can look at this philosophically. Are you changing the nature of the muscle? Now, when you do a laryngoplasty, what you're actually doing is extending the inner table of the thyroid lamina. That's why the Gore-Tex is logical. You're not changing the muscle. You're actually making the inside of the thyroid lamina extend medially. So what muscles that are denervated are there are just compressed a little bit. But when we start putting materials that don't belong in a vocal cord, and that stuff, I have had the worst time trying to, it doesn't aggregate. It actually goes and dissects in muscle fibers. We don't have the time, but I could show you these just monstrous cases of where and when the person doesn't understand pliability and they keep injecting the hydroxyl apatite in, they now achieve almost nothing if they expand it too much. Because remember I said that you want to engage the superficial lamina propria that isn't? They put so much in there and they expand it so far because they're not getting what they want. They put extra surface tension on what's left. And now you have a complete disaster. So and you can't just get it out because it's now dissected all in the muscle. And I just think these are not wise materials to be placing in vocal cords. And you don't have that. The other thing that was great about the Restylane, I have nothing with this company. It just worked. I have no interest in this company whatsoever. It's so inert. And there's been so much studying in skins of faces and things like that. The amount of actual scientific research in those materials is massive. And if there was going to be problems, it would be creating a problem in people's faces. And that scientific foundation, to me, gives it safety. And when we look, you'll see it in that supplement, it was just aggregating exactly where you want. We then did MRI images of these dogs, larynges, and it was just easy to use. You went in the ventricle, you leaned with the needle on the thyroid lamina, and you just put it in. So it's very easy to manage. It is not water soluble, so it doesn't hydrodissect in fascial planes. And then on top of it, it just goes away and it's practically inert, and it'll go away anywhere between 2 and 4 months.
Thank you very much, Ahmed, Stephen. And Pedro Nuno from Portugal is a voice teacher. He wants to ask something you.
Sure.
Stephen.
Greetings from Portugal. Dr. Stephen, I have a question. What is the role of speech therapists and teachers of singing during the recovery of those singers that went to surgery? And if could a better technique avoid this kind of lesions? And this is my
So my answer to your first question is they're critical, critically important. Maybe that's 2 words. So the people that I'm seeing less conservatory students now. My younger partners are caring for them. I've just gotten very selective on who I'm operating on, bluntly. I just got to a point I can't spend all my time in an operating room. So that's why I have younger partners, and they need to learn because I'm not going to be around forever. Now, when it comes to this, all 3 of our voice therapists are classically trained, all of them. That's almost one of them still does cancer as well. It's a paramount importance. This is a standard situation for us. They will be evaluated. We'll do acoustic and aerodynamic testing. Most people I operate on, most things, I meet hours before the operation. They'll have whatever they have. They send me a video. I see the lesion. I do surgeries for this on Tuesday. They show up on a Monday. I discuss everything about the surgery. I probably talked to them on the phone already. After I finish doing stroboscopy, I go straight to one of our voice therapists who is going to actually prepare them. I don't have the time to tell them all of the things to expect. So we're a team. We're intimately related in this, and we have a grand piano. about 15 feet away from where I see them in a performance room. They evaluate them. They do the acoustic and aerodynamic evaluation in a soundproof room. I do the surgery. They don't start doing anything without like when I see them post-op, they go straight to the voice therapist again. Then the challenge is so few of these people live around here in my practice now. They connect with them to get either a teacher. And I think both things happen. Sometimes it's a teacher who's known their voice. I don't think it's kind of magic. I think the person has to have a rapport and feel comfortable. And everyone's a little different about that. And more often than not, they're working with the person they know well, or they identify someone if they haven't, had a decent coach or something, they identify and we help them do that. But back to your original question, I couldn't do the things I do without an intimate relation with voice therapists and speech pathologists.
Thank you so much for your answer.
Yep.
Yes, and thank you, Pedro. Thank you, Stephen. I think also I would like to ask you if what is your experience now with the singers that have been gone under surgery during this pandemic and during this time? Because I have seen many complications due to reflux, due to stress, due to lockdown. I don't know which is your experience, because every country is different and every position is different. But I think in general, the human beings, since last year, we have been under such a special stress that is also influencing the development of the post-surgical treatment and expectation of the surgeon.
Well, one of the, I think we're all as clinicians looking at how did COVID change things. And, I do a tremendous amount of airway surgery, and I can tell you, this is just an interesting time because we're in the process of there's one paper, and I'll get to your question, one paper in that supplement that addresses a new way to mobilize vocal cords with a sort of an unusual innovation. We're going beyond that now. And I have not had so many new airway patients come at me as I have right now with all kinds of disasters. But it's also the singers. What the main thing I would tell you is that I'm operating more on singers now than almost I ever have. And the reason is they can't work. So if they were thinking about having it done, they're getting it done because they're not losing money. I have to tell you, folks are like, I'm just getting these calls, and this one calls that one and that one, and can I get this done? Because it looks like things are opening up or will. So this year of COVID, once we got past the first 6 months of last year and it was becoming viable, I've had more singers contacting me. It was just that and glottic stenosis. Those were the two things. And I was so surprised. But then after a while, you talk to them and say, this is my opportunity. I'm not, I can't do anything about it. So I'm coming in and getting this done. Because picture this, and I say this as I, give general lectures. There's very few things that I operate on that haven't been there for at least a decade. If you even take cancer, okay, it doesn't go from normal to cancer, it's dysplasia for at least 10 years. And even a T1 cancer has probably been there 12, 15 years, and glottic cancers don't accelerate till later, till they start growing a lot. You take papillomatosis, I'm not seeing them. You take vocal nodules, polyps. I'm trying to share things because I've been taught so many terrific things by so many terrific people. And my fellow this year recently asked me, what's the difference between a nodule and a polyp? And that always presents, because are we looking at this thing architecturally, or is there something different about the pathology? So when I wrote my thesis about vocal cord cancer and came out in '95, I had mentioned this absolutely brilliant surgeon from Slovenia. His name was Vinko Kambic. And next thing I know, I'm the sole American invited to this European meeting. I'm a kid, and they're, getting through the war in Yugoslavia and everything else. And I show up there in the middle of the night, and I thought this, I was like 33, 34, and I read what this man wrote, and he was Kleinsasser's contemporary, but he was in Eastern Europe and didn't get the recognition. And this man saw that I referenced all his stuff because I dug and dug when I wrote the thesis. So I show up in the middle of the night it's in Ljubljana, and you know, I'm the youngest one there and a Yankee. This didn't make for the most comfortable situation. And he was such a perfect gentleman. And he made me sit down next to him. And he looked at me and he said, "What do you want to ask me?" Because I knew how brilliant he was and he knew how brilliant he was. I said, "What's the difference between a polyp and a nodule?" And he just looked at me and smiled. He said, "I don't know, one's bigger." And he's right. When I operate on them, what I do with a polyp, I try to turn it into a nodule by making it smaller. And then you approach it. It's the exact same operation done in different scale. You're identifying the superficial lamina propria that is still functional, and you should see it. What the Atlas did years ago is I didn't take pictures to a telescope of the surface. I had the vocal cords open so you could see the interface, be it a cancer or be it a benign lesion, to the normal tissue underneath it. And therefore you knew where you had to end and you wouldn't take SLP unnecessarily. So when everything is said and done, these people are now coming in because they've had problems for years. I mean, Keith Urban had problems for 20 years. He didn't even know he could be made better. So we've come a long way from what happened to Julie in the 1990s. It really was Adele's operation that changed. I was operating on people because they couldn't go on any longer. But Adele's, all of a sudden, people aren't as scared anymore. That it became routine. And then there were a series of, things in the news. It just has to be done right. And what we tried to do through these papers, and the one recently, is just physically demonstrate those steps. But the premises are pretty simple. Don't take extra membrane if it's a subepithelial lesion, which is benign, and take the membrane if it's a disease. And that's all there is to it. You just have to have, that level of confidence that you can do that effectively. So the big COVID thing is I'm operating more on singers because they think it's a good time to do it.
And what about reflux? And
I just treat them all. I don't know the difference, Eugenia. I figure any of these folks, I can see the difference in some of them and it's outrageous, but I just treat them all. I educate them all about, what to eat, what to drink. I certainly won't let them have surgery without being on a proton pump inhibitor. I'm not going to figure it out. I'm not going to work it up. I'm not going to put a pH probe in. I'm treating them all because I don't have time or anything to start turning these things into workups. I just treat them empirically and they decide whether they want to stay on it or not. But, one of the things that I mentioned in the early part of the talk is that my practice is predicated on diseases, not one-off events. Any type of lesion that a singer has is a one-off event to me. They come to me not for their general care, they come to me for the surgery, and I might see them once again in the year and that's it. Even a paralysis is a couple of events. I might inject it, as I said earlier, but they're not disease processes that go on. I'm not the person who, I will have my folks do that kind of management because I don't have the time. But I think it's important to realize that if you can, the idea is to help singers like an orthopedic surgeon get to where they need to get to. I had somebody come in from Nashville, like 2 in the last few weeks, and they were in a pathway to have endless office examinations and stroboscopy and endless voice therapy, and they didn't need it. They just needed operations. The patients, and that's what happened to Keith Urban too. It was like, well, there's no answer. We just keep examining you and following you. And some of these people just need to have a good operation and really stick in the end more with their voice coaches and teachers. But I have a bias in that direction, it's clear.
I agree completely with you that we need to have an integral vision. And of course, what the singer needs and all the practice of their own habits, they can be made by your team. And Dr. Haldun August from Istanbul is going to ask you something still.
Thank you very much. Can you hear me?
I sure can. Am I visiting you this year? What are we doing?
Yeah,
we've been putting this thing off.
we still hope so. If Corona,
all right, no, I'm leaving it open. We've been trying to get together in Turkey for, I don't know, it's a year and a half or 2 years.
Yeah, thank you very much. Thank you very much, Eugenia, for this wonderful night. And I am very pleased to see Steven live, face to face, although I cannot touch him. I cannot find the exact words how I admire Steven, because I had the privilege to spend 4 months with him like 16 years ago. And this was the most important, most valuable, most compact learning period for my whole professional life. So I was just following his steps.
Thank you.
I just tried to find the exact same flexible in my office. I tried to make the same Gore-Tex thyroplasties. Now I have the blue laser for papillomas. But Steven, I have one question. Perhaps you may have told about it during your speech, but I had some internet connection problems, so I just fell and came back. What will we do with the sulci? It's not, of course, with professionals, but what will we do with the type 2 sulci, the sulcus vergatur?
I'm sorry, I don't memorize the names. People start naming and numbering. If you're talking about the diminished pliability in the center part of the cord, you know, to me, diminished pliability is a depression. I don't think there's a good answer for this. That's what the biomaterials, I don't have the logically to try to resect those things, which is kind of the question someone asked me earlier about Steve Tyler. The entire center of his vocal cord is a phonotraumatic sulcus. And I don't think there is a way to make that better. I think that's when there's a mass lesion, then you can get there. Otherwise, I think it's going to be a biomaterial. I don't have a wonderful way. And then what really worries me, and I've seen this really destroy a few singers, we have to remember that let me just back up and say, the density of motor wiring to a set of vocal cords is the densest motor wiring. If all you did was take the caliber of the nerve to the muscles it innervates, it's the densest in the body. So, you know, the RLN, maybe it's 60%, 50% of the facial nerve, but all your vocal muscles fit into one corner of one facial muscle. And I can't sing to save my life, and I can do this. Okay, why on earth, that is the gift, the brain to that wiring to these people, how they do what they do. Would you want to put something that's a space occupying foreign body in the middle of that neuromuscular function? So it's, to me, so simplistic to say we're just going to push them over and it's all going to work. And I've seen singer after singer destroyed because the people are first order thinkers when they want to just close a gap. That neuromuscular wiring is so critical to what a singer does. And this is a long-winded way of saying I don't have an answer, Helen. I basically avoid, you know what I do? I spend a tremendous amount of time talking to them and preparing for them for the inevitable. You will work with a teacher. You will find somebody who can try to manage your system. I don't think it's in my own hands, and I've done a lot of surgery. I've probably operated on, I don't know, 750 singers, let alone people. I can't fix that. I don't have a pathway. What I may do is put them asleep on occasion, but I can usually do this in the office, and infuse and hydrodissect their superficial lamina propria. Just put a needle in the office in the OR. If I bring them into the OR, it means I want to geographically define exactly where the problem is. And maybe, just maybe, I'll see something that I didn't see under a microscope and retracting that I can fix. But I don't have a straightforward way to fix it. And I think cutting them, it can just so often lead to heartache. You can try some of this stuff in a speaker, because, you know, these are things that I think people should know. When I speak to you and I give this lecture, I would bet I'm using 5 to 8% of my biomechanical capacity of my vocal cords. You heard what I just did with my voice. A singer uses all of it. So you can do a lot of things to a speaker. By the time you have gross hoarseness, you are down to 2 or 3% of its biomechanical capacity, because you only need 5 or 7% to have a conversationally normal voice. That's why we get such great cancer results. We basically they're using the other side or half of one, you know, but when it comes to violating that neuromuscular relationship with the hope of pushing it over, I just don't think the trade is worth it. And I've stayed away from it. I will resect lesions. and I do the variation in pitch in the stroboscopy, that's what teaches me. There isn't imaging available. We would wish that OCT would tell us how deep and how thick the stiffness was. It's not there. The best way to do that, you get them low and you see what kind of wave exists in the low frequency. Then you bring them up high, and you know that's the best way to guesstimate how much viable superficial lamina propria is left under the lesion. It's that they're their own control in the pitch task, how loud they have to get. And then in your mind, you have a three-dimensional view of the shape and size of that lesion. And then when you get to the OR, you're not surprised. And the first move is to get to that interface of that scar to the underlying normal superficial lamina propria. So again, a long-winded way, because I think people should know it. I don't think there is a way to fix that. It's a material. Those are the folks, the presbyphonics. You can imagine when somebody comes up with the right material for this layer, and it won't be so easy because remember, if you've lost it down to the ligament, you have to prepare the recipient site to take it, or else if the needle goes in, it's going to come right out the hole. So there's going to need to be other maneuvers, and we have some ideas how to temporarily dissociate the basement, again, those basement membrane zone proteins from Steve Gray, that you'll have a chamber that you can actually put a material in. So a lot of this is just, it's the future, but I think it's what's going to support the field in perpetuity when the science catches up with it. And I will not resect the sulcus. I will just spend time talking to the patient and recalibrating their aspirations, because what tends to happen with these folks, everyone wants to be their hero. Every surgeon wants to say, I can fix this. And they go surgeon to surgeon, they become Munchausen's patients. And oh, I could try this, and oh, I could try that. And I just seen these things where people have had 10, 15 operations, and all I'm looking at is the complications from the surgeons. So I'm very, very hesitant to dissect areas where I don't think there's a mass that I can resect. And we have to be in touch, because I got to know when I got to put the time in to get the turkey.
Yes,
we had
please
prior
do
plans.
so.
Thank you, Stephen. Thank you, Harold. I don't know if somebody from the audience has also something to comment or to ask. I also would like to ask you about your experience. I don't know if I am right. I saw the new 3D stroboscopic machine in Berlin. This is from Xion. I don't know if you have this experience with Xion also, or somebody,
I don't.
another company, Stephen, because of the 3D surgery. This is an interesting situation.
Well, with 3D stuff, I mean, I haven't, so I can't talk with any intelligence about it. When we really want to get some really in-depth information, we just use the high speed. And so that tells me everything that I need to use, but I don't have any experience with it.
Mm-hmm. And did you make some surgery with under this high-speed camera?
No, that's just for office examination. Oh. I've been doing the same thing I've been doing, which is the highest magnification I can get, the biggest scope, which is why we're coming out with these new scopes. We're always trying to maximize the inner diameter and the shape of the speculum for the outer diameter. Things were done fundamentally unsound for so many years, putting large light cannulas outside, then the scope doesn't fit in between the inner table of the mandible. And so what we did many years ago, and all these have, is the actual light is in the wall of the scope itself, and the only place where there's free real estate, which is the floor, because it faces the pharynx. You don't want to have a light coming in where it's going inside the mandible. So, I just maximize those things. And I think the suspension is, here's a sort of a pet thing that I have. People write papers about the complications of microlaryngoscopy, and they say, oh, you use a suspension, you might get a numb tongue, or you might tear the floor of the mouth. That's the goal. The reason that's tearing is because nobody else can get a view of it in the first place, and you failed with the operation. You need to act, this is surgery. If you can't get a decent sized scope, and your scope caliber is the most important rate limiting factor to precision in the lumen. nobody can do a precise operation through a narrow scope. And we all do the same thing. When it doesn't fit, you go to a smaller scope. So the idea with a suspension as necessary is to tear the glossotonsillar sulcus so the laryngoscope gets to the anterior commissure and you can do your operation. So when folks write there's a complication, it tells me they don't know how to operate. Because if you didn't, they're not telling you all the times they didn't tear it or something, and then they never got the operation done, because that doesn't get into the study. So the goal is to get the best view you can, and that requires a suspension, lifting the patient up, and as necessary, very extensive external counter pressure, so that as you lift the patient up this way, the tape is pushing it down so you get the view of the larynx. And I warn patients about it beforehand, that, you know, you may have a numb tongue, and I've never seen it be permanent. The longest I did see one, she was so retrognathic and she had relative macroglossia, no one else could even tube her. You know, she had a numb tongue for 5 to 6 months, but it went away and that was it. Because you're not cutting anything, it's just 2 hours of pressure in suspension on that area of your tongue.
Yes, yes, and of course, we have also the experience in some of us with local anesthesia surgery on the stroboscopic light. And I don't know if Marcus is also making high speed, but I do make surgery without laser on the local anesthesia.
How do you retract, Eugenia?
Different scopes.
How do you retract if you got one hand on the scope? How do you retract the flaps and things?
Well, it depends, because sometimes I use the 70 degrees endoscope, and so I can leave the endoscope. It's like a tricky thing, and I can leave the endoscope, and then I use both hands with the instruments. Things like that can happen.
But you are using a screen. You see, but you are using a screen, which is two-dimensional. You don't have depth perception.
Yes, exactly. That's
now,
why.
If the person, I mean, it's so one of the things that I always thought was very, very, very interesting, and older colleagues told me this, there was substantially more advancement. Well, picture this, if you go back to the original instruments, I have a bunch of them, and I looked at the papers from the 1860s, 70s, and 80s. You know, what made the field eventually is cocaine. Cocaine comes in the middle 1880s, and now you can do all kinds of things with a mirror. And I had discussions with some of the older European surgeons, and a lot of the development of transoral mirror guided at the time was somewhat related to the lack of, I guess, the economic system to put people to sleep. It was too expensive to put all these folks to sleep. And so they got insanely good at developing. So it's one thing to do it with a mirror, then the scopes got better. So those folks were highly skilled at doing office-based procedures out of necessity. But, you know, what happened in, you know, many of the Western countries, like the US and, you know, and others, when you started using general anesthesia, which comes in, you know, with a microscope in 1960, now you had a magnified, stable, they were sleeping, even if it was spontaneous. So that allowed for more, the precision was bimanual dissection that was stereoscopic. So I still go by that, but I think there are plenty of things, should I want to, I could do a reasonable job. And that actually just pertains a lot to the way the medical system's constructed. I mean, if you're in a situation, I mean, I had a fellow or a visitor from India, they said, we have so much cancer, we can't do the things you do. We're sometimes taking out 5 or 6 cancers a day. You know, we can't do the things that you do. So a lot of what gets done has to be commensurate with the society and what is the patterns before. But I think the skill sets to do office-based surgery, I think people in general in the Western world are not nearly as good as the people who never stopped doing it for 100 years in parts of Europe and other parts of the world.
Yes, yes, I think so too, because the advantage of having the function during the surgery is great.
Immediately, yes, you're right about that.
I don't know if Marcus has done from, or Joseph or Andrea have done something with high-speed camera, Marcus. I mean, surgery under local anesthesia with high-speed camera.
No, not really with high speed, because I don't see the advantage. But I think there's a little bit more of advantage for office-based surgery. And I think that also with the flexible transnasal surgery, if you learn the skills, you can do a lot in the office. You can do infusions. You have to get very close to the vocal folds. And one of the key issues is, how do you do the topical anesthesia? But I think this is skills that have to be trained a lot, like phonomicrosurgery as well. But it has its armamentarium, its place in the office. And I think we need to do more.
Thank you. And Andrea, you have something to comment?
I agree with him, absolutely. I also say that high speed is useful also for diagnosis, not for treatment, not for phonosurgery, of course.
I would like to make phonosurgery with high-speed camera. And Joseph?
They're too heavy.
I know.
The device is heavy.
I know, I become with the big camera. But anyway, the thing is, in office-based surgery on the local anesthesia is the advantage of function, but also if you have a proper anesthesia, you can handle all the kinds of scopes, either flexible or rigid, with the different augmentation, for example, for the 90 degrees shots, and I think you can have a very good view. And also the other thing, as you know, Stephen, and we have talked about many times, that there are sometimes in the different hospitals, for example, in Mexico country, not only Mexico City, that we do not have all the kinds of armamentarium.
I agree with you. That's why I said it depends upon where you're working. You're right.
That's why we are trying to insist in the possibility that the skilled phonosurgeons have to be trained also in phonosurgery under local anesthesia. And of course, they have to be more careful than under general anesthesia because of the situation of the mobility of the vocal folds. I don't know, Ahmed wanted to ask something. Yes, Ahmed?
Yes, actually it's about a different issue, and mainly about two things. The first one is we talked actually about the augmentative materials. I wonder if you have experience with Aquamid or polyacrylamide, which is being used in South America, and South Korea. There has been some reports on it, including reports of a granuloma. So I wonder if you.
No, I don't.
Okay.
But you know, one of the things I think was interesting was you know, I have seen Teflon granulomas. In fact, when I really started my practice, really gets taken up by the lymphatics. And I went in to do a laryngoplasty because it was injected for paralysis. And I found it in the cricothyroid space in the Delphian node. It was full of Teflon. Now, one of the things that Herb Dito used to say, and he's actually quite right about this, granuloma is a funny term because are we talking about the use of the word as a histological finding, or is it just like a granuloma in terms of its physical appearance, like you would get on an arytenoid from someone who had just trauma and coughing after a cold or an intubation? And the reason that's important is, and I don't know the papers, I haven't used this stuff, but the majority of the Teflon granulomas, Dito used to say, were just over-injected vocal cords. And they didn't, the surgeon wasn't taking ownership. It wasn't a reaction to it. They just filled it up. And that's what can happen with the hydroxylapatite. And that's a very different thing than a foreign body reaction. That's a granuloma. And, you know, so I think those terms, just like the term polyp, these are vague, descriptive, sort of, you know, just what does the tissue look like? And it's not necessarily what's happening histologically. So I just think that's worth bearing note. It isn't always just the material, it's the person doing it too.
Yes, yes.
Thank you, Stephen. Yes, Peter.
Thank you for this great talk and discussion. I would like to make one comment and one short question. My experience and opinion about presbyphonia is I use semi-occluded vocal tract exercises with high back pressure, something like over 15 to 20 centimeter water. And I see generally a better way of speaking, and the life term is changing after using for 3-4 weeks. And in some chosen cases about versature, it also works to some extent, the high back pressure with semi-occluded vocal tract. My question is, do you use fibrin glue or suture to the epithelium, and when do you decide to use it?
Okay. Well, I'd like to address your comment. That makes perfect sense to me. When we looked at our Ranke's patients 20 years ago, the average, they were 10 to 12 centimeters of water to drive those vocal cords. So that's the kind of pressures you need to drive. There you had mass. This, you need those pressures to basically drive the stiffness. And so I think what you achieved with this, remember I said in any type of presbyphonic, they've worn out the zone that normally hits. When you drive them with that much pressure, you're engaging those areas that if they just had a little bit of an augmentation, the combination may do amazing. Because I think what you said makes absolute sense. You're driving them into such a greater degree of vibration. You're using pressure rather than them squeezing so hard, because it's a bit of a balancing act. And that is something I do. I mean, credit to you for figuring out how to get people to do it. Just the same way Steiner, when he came to learn how to do cancer surgery from my teachers in the 1970s. And the first thing he did, because he didn't have malpractice there, is he went home. He was just whacking these vocal cords in a way. We were doing it in the VA hospital because you couldn't sue a government employee. So in America, none of those vets were suing. Steiner went back and ran, and one of the first things he did, he got a great speech pathologist and voice therapist to convert the glottic speakers into supraglottic speakers. So the manipulation, when it's done very logistically, of the system to achieve what you want. So what you said makes perfect sense. I'll bet you if there were good deep injections, you would get an even better voice. So it's like a Parkinson's patient. You actually, in many of them, you try not to do procedures, but if you actually inject them and then go through LSVT, it's much easier. So that was the first thing. Now, what was the second question again? Well, the first question and the second comment. You asked me a question I wanted to address because I thought what you said made great sense.
The suture or fibrin glue for the epithelium.
So I tried fibrin glue. I couldn't convince myself that was going to be there the next day, given the saliva and the spit and the secretions, and so I didn't pursue it. I'm very strategic in the length and width of the flaps. I think they just stay together by capillary action. In other words, if I make it too long in either direction, that's how you can get a funny effect. It can roll in the flap. And so I'm very strategic, and I usually don't have to make them front to back. I suture all the time, but I don't suture unless there's something major going on in the glottis. Most of the suturing I do, and I'm doing a lot of it now, is for these stenoses, because I'm raising all kinds of unusual flaps as how should we say, I've been able to unstick vocal cords in a way I never thought was possible, because I mistook the fact earlier on that there was an injury to the joint at the cricoid facet, and they weren't. It was all soft tissue. And we wrote about that there is actually a way to remobilize joints, because it's not I shouldn't say it, remobilize an arytenoid, because the joints are only injured by surgeons. Tubes never get there. So now getting back to what you said, so an example of when I would suture is there was a woman, and this is just a typical case. She was a lung transplant for cystic fibrosis, and the surgeon is, just loves to inject, has a reputation of doing that, and filled both vocal folds up with hydroxylapatite because the person didn't understand stiffness. And so the more he put in, I had this massive amount of hydroxylapatite, and it still didn't fix her denervation, which occurred from the lung transplant. So what I did was I made a superior surface epithelial cordotomy, and I peeled out all the stuff and I stitched that together. I won't put a stitch on the medial surface. I stitch all the time. If people want to know, if you're going to stitch inside a larynx, and this is more for moving tissue around, like fibromucosal flaps and a stenosis or something, use Prolene. Prolene is one of the most inert sutures. It's why you see it in trauma cases when they come in. When I do the cricothyroid subluxation, which was to get better tension on the laryngoplasties, I still, in many of them, see I go under the cricoid, stitch it to the lesser corner, and then I pull tight to simulate the cricothyroid muscle. To this day, I'll see the blue suture sitting there inert. So when I have to do suturing, I'll use that. The problem we have with the suturing is the needles aren't small enough. And talk about challenging, the needle drivers don't hold them. And so I do a fair amount of suturing, but I'm not in favor of putting it on the medial surface. So I need big flaps where I've made big incisions to do something like that, or maybe some unusual cancer cases where I'm flipping tissue in there, you know, a whole range of unusual things like that. Another place where I stitched is I started encountering more teenagers that were neonatal prematures, and when they were neonates and like born at 2 pounds, they had a tube in and they ended up with diastasis. So when we wrote this concept up years ago, we realized that this was kind of crazy. There wasn't, everyone gets it because if you put a stent in to fix a stenosis, you get diastasis. I had asked my Greek friend, what's the word for permanent separation? We know what it is to suck closed. And he said diast, and that's why you have a diastolic blood pressure, and that because it separates from systolic, and that's why a woman after a pregnancy has a diastasis rectus. So I would see these kids come in at 18 or 20, nearly aphonic. Their vocal membranes look fine, but they can't close because they have a keyhole aperture. So I started doing a lot of suturing at the glottal level by raising flaps in the supraglottic interarytenoid region and rolling it down and filling the posterior glottis where they had the keyhole from the original tube when they were a baby. And I mean, they didn't get great, but they had voices for the first time. They grew up their whole lives. So I don't do suturing on the musculomembranous region. I will do it in the posterior glottis. Because it's, and again, the problem with the Prolene's a great suture, but they don't have small needles. So it's tremendously difficult to do it. I hope that helps.
Thank you very much. Now, Marcus, if you would like to ask something.
Yeah, Steve, I was wondering if you're doing transgender surgery, and if not, what do you think about the glottoplasty, so the suturing of the anterior parts of the vocal folds, and what are you thinking about this LAVA or modified LAVA operation where they laser away and mass reduct the vocal fold muscles, the TA muscle? So what would you do? What do you think is the better technique?
I don't know that I have enough experience to give you a high level explanation. I mean, I've done most of these things over time. I tend, call it a certain kind of bias. They're very labor intensive to deal with. And I actually have so little time. And it's just because they're, you know, bluntly just complicated people. And a lot has gone on. So I have done virtually, I have most of the operations. I've shortened the glottal aperture. I've done cricothyroid approximations. I've done all this stuff. My experience is sort of interesting, and it's somewhat based on other experiences with glottic surgery. I'm a little concerned about the shortening of the glottis, even though I think you can get it to work, you know, the area that's functionally pliable, because I've seen so many patients who have had cancer surgery, papilloma surgery, and they can actually talk at that frequency with a limited amount of superficial lamina propria because it's three-dimensional, like Reinke's. So I get worried if I just shorten it. I've had some success, but I can't say that I feel I have done enough, Marcus, to say I can reliably hit the mark. If I really want to get the voice higher and hit the mark, I'll just go to a cricothyroid, you know, approximation. It's very easy to do. You use Prolene, they all tolerate it. The problem, as you know, they're not elastic voices. And, you know, a person, just because they're like this, that doesn't mean they sound like, you know, a gender reassignment. They have to get the prosody. And so I've had experience where I changed the frequency and I got them living at 180 to 200 hertz, but that didn't really take care of the problem. And so, you know, what we learned in looking at frequencies, a lot of this came in the 90s when Bob and I were looking at this. You know, we don't operate on a lot of Ranke's patients who are men because they don't care if they're 80 hertz. What we realized, if we did subepithelial reduction and then just reapproximated the membrane, the majority of the women were going to live at about 150 to 170 hertz, unless you scarred them. If you did, you could get lucky, you get a scar and they get up higher. But the interesting thing there was, I didn't know what we were going to get it to, and so I felt a little bad. And then Bob looked at me and he said, Marcus knows Dr. Hillman very well. So Bob looked at me and said, "What are you worried about? That's the normal frequency for a female smoker." So we got them to there. So this whole issue of where you put these frequencies, so again, I've done a limited amount of this, and I go first to the outside of the neck because you can make a tiny incision. Then I'll start, a few of the folks wanted me to keep pushing it, but I get worried about scarring them. I don't know that I can control that well. You're giving me vertigo, Marcus.
Thank you very much, Marcus and Stephen.
Thank you. Thanks for the.
Yep.
And I would like to ask if somebody from the audience wants to ask something else or to make a comment. Okay, so I thank you dearly, Stephen, and I thank all the CoMeT members, my dear friends, and many guests. And I wait for you on 17 April. And do not forget that we are a big family. And of course, we shall meet in April and in May. And well, I wait for you also in CoMeT session in the Voice Foundation and also in CoMeT September. And many dear greetings to Marco Fantini. I think I didn't say hello, but anyway, thank you.
I just would like to say something before you sign off. I've been at meetings with many of you over the years, and I kind of like little bit went underground a little bit for my children. I got married very late in life. I was a surgical roadshow into my 40s. So if you haven't seen me much, I married a Chilean otolaryngologist who I met being the guest of their country. We have 2 kids now. So now that they're getting older, I'll be around a little bit more. And it's just great seeing you all. And it was a real pleasure to have the opportunity to share what we've been doing for the last 25 years. And anyone wants to visit, the pandemic will end. Please come. We accommodate people and glad to share what we're doing. And, I think a number of the people on the phone have spent time with us. We love visitors, and there's just a lot going on. And again, I appreciate your inviting me to do this.
Thank you very much, Stephen, and of course, many dear greetings to the family. And we are a bigger family, but many, many dear greetings to Maria and your children. And thank you very much for staying with us. And I think our CoMeT family is great to hear all these experiences from people who are really expertise, and of course, sharing with us in a very friendly way, and also without the time limit. And I thank you very, very much, Stephen, and also your patients. You are right. We have to be very thankful to our patients also, and to think of the patients as a real human team. And of course, this COVID time, well, we shall see next year, perhaps in Tel Aviv, because we are planning this CoMeT meeting in Tel Aviv at the end of April, first days of May, but we shall let you know. And Stephen, thank you very much. And everybody, dear greetings to everybody, and thank you for your patience, and thank you for staying with us. And I see you on April.
Thank
Bye-bye.
you, everybody. Bye-bye.
Ciao.
Thank you. Have a wonderful night.
Ciao.
Thank you. Bye-bye.
Bye.
Bye.
Thank you.